Thank you. So yes, here's an overview of our session. It's a really great lineup of speakers today. It is a packed session. We do try to keep our webinars to 1 hour so that people can join us in their lunch break more easily. So for that reason, with apologies, we're not going to be able to take questions, but again, use the chat function, pop any questions or comments in there, and anything that's not addressed during the session can be picked up afterwards, and we will be checking through the chat as we go and afterwards. So you'll be hearing from all of these speakers later, but before we start, I'd like to start us off, I'd like to invite you all to take a quick quiz at slido.com. There's a QR code there, or is there a link in the chat? I can pop a link in the chat. And it's just going to be a series of 3 questions. Sorry, put a link in. If we could go on to the next slide, Teresa. Fab. So the first question is, do you know the difference between a learning disability and a learning difficulty? So I'll give you a few seconds to answer that. It's looking like a resounding yes for now, which is nice and positive. And a few unsures and no's popping in. Lovely, very interesting. And then perhaps if we go to the next question now, which is it's going to generate a word cloud for us. So if you can give an example of a reasonable adjustment that you can think of, and just pop that into the answers. So we've got extra time and appointments, longer appointments, longer waiting times. Oh, fantastic. Easy read format. I see lots of things coming through here. Visual cues, advocacy. Fab. Thanks, everybody. What we'll do is you can carry on filling this in, and we will share the word cloud with you afterwards as well. And then the third question is another quick one. Have you heard of LEADER? Yes or no? Okay. So a bit more of a balance there. So that's very useful for those of you who've answered no. You'll be hearing all about LEADER from Graham shortly. So that's very interesting to see that. Thank you. And great. So now that we've kicked off, I'm going to hand over to my colleague Alison. Over to you, Alison.
Thanks very much, Susie, and that was fantastic. It was really helpful for us to see that there's a lot of knowledge about learning disabilities, but people have got some gaps, and that's exactly what we were hoping to address today. And so we do apologise for the speed we're going to go through today, so do put your questions in the chat, but it's only because we've got lots to share. So next slide, please. I thought I would start with what is a learning disability and how many people have a learning disability, so you kind of have an idea of where to start. And it's often poorly recorded, but we think there's at least 1% of the population has a learning disability, but it's very likely nearer 2%. And the reasons may be various. It might be genetic, such as Down syndrome, non-genetic malformations, or if a baby's been born early before 33 weeks, and also sometimes prenatal problems. And I'd also like to point out this photograph of Piper, who is Susie's goddaughter, and thanks to Piper's parents for enabling us to have this photograph to show these are the people we're working for. We want to improve outcomes for people with a learning disability. Next slide, please. So what is a learning disability? It's also known as an intellectual disability. Lots of controversy over the naming, but intellectual disability tends to be used more by academics, but people with a learning disability themselves tend to prefer learning disability, so that's what we use. And it means that people often have a reduced ability to understand new or complex information, might be slightly slower learning new skills, and might be less able to look after themselves. Whereas a learning difficulty doesn't actually reflect general intellect, and examples include things like dyslexia, ADHD, or dyscalculia, so trouble with numbers. And it is important because sometimes people with a learning difficulty, such as dyslexia, might be inadvertently on the learning disability register, which we'll mention in a minute. So therefore, it's just important to not have that term. And once you become aware of it, you'll realise how often people use the wrong term. Next slide, please. So how do you work out if somebody's got a learning disability? We used to work very much on IQs, and thanks to Sam Browning and the team from Leeds who shared this document, and it can be divided into mild, moderate, severe and profound, but on the IQ range. But it's a bit of a blunderbuss tool, and people had to be referred to find out if they'd got a learning disability. And this is no longer in use, but I thought I'd include it just so that you're aware that that's where some of the terminology comes from, but we don't actually use it. Next slide, please. So this is the Learning Disability Register and Inclusion tool, which we'll share afterwards. We're also going to have a QR code so you can take a photograph and be sent to the link. And it's a really practical and pragmatic way of identifying if somebody's got a learning disability, and you don't need to refer somebody for that diagnosis. Next slide, please. And it's the things to think about it. It's just looking at the person in front of you. Did they go to a special school? Are they involved with the Learning Disability Service? Did they get qualifications at school such as GCSEs? Do they need help to read, such as appointment letters? Next slide, please. But this is the bit that really can be really practical, that it's easy. Does that person need help writing? Are they able to live independently? Are they able to learn new skills? Are they able to understand new or complex information? And those are the kind of questions that you can think about asking to decide if somebody should be on a learning disability, have a learning disability. Because if they have, and Rachel will go on to it, if they're put onto a learning disability register, we can offer extra care and support. Next slide, please. So I hope that's just given you a quick understanding of what's a learning disability and what's a learning difficulty. And now I'm going to hand over to Graham to talk to you about LEADER.
Thank you very much, Alison. For those that haven't met me, my name is Graham Carr. I'm the head of programme for learning disability and autism across the Southwest, and I have the pleasure today to talk about LEADER and the difference it can make. Also on the call with me is my excellent colleague Nikki Powell, who is our Southwest Regional lead, and if you've got any questions about what I'm talking about today, please drop Nikki a line. I'm sure she'll put her email in the chat to answer any questions. Nikki will also be marking my homework to make sure that I tell you all the right things. So if we just go on to the next slide, please. So the LEADER report is full title is Learning from the Lives and Deaths of People with a Learning Disability and Autistic People. So it's a long title, often referred to as LEADER. And this is an exceptional tool, really, across the UK or across the world. It is a leading database of understanding the inequalities and the health concerns of people with a learning disability and autistic people. More so learning disabilities, but certainly developing with autism. The aim is to improve the quality of care for people with a learning disability, as well as reduce the inequalities and in their delivery of care. And you'll find as we go through the next couple of slides that there is inequalities still present in the delivery of care. So if we move to the next slide, please. So we know from the most recent LEADER report that the average age of death for a person with a learning disability is 62.9 years. So when we look at that in comparison to the general population, is 82.3 years for males and 85.8 years for females. So the disparity is huge. When we start looking at ethnicity in relation to learning disabilities and the length of life, then we see that actually you're almost 200% higher chance of dying early if you are from a Black or Caribbean African heritage, which is incredible. And I think it still goes to show that there is work to be done. And hence why LEADER is a real focus for us, because it is highlighting these range of concerns. If we could just move to the next slide, please. So the most recent report found a range of common causes, and I'm sure in your own practice you might have experience of this anyway. So around circulatory problems, cancers, respiratory problems, and nervous system problems. Of course, there's also the genetic disorders as well. Other causes of death also include things like endocrine and metabolic diseases, kidney failures. COVID still accounts for deaths within the learning disability population. So really keep an eye on COVID vaccinations. I think that's a real key, not to forget that as we move further away from 2020, but also things like dementia and Alzheimer's as well have a significant impact on people's lives, certainly with a learning disability. We could just go forward one more slide, please. Avoidable deaths is huge. So we know that about 22% of population deaths can identified as avoidable. That's double that for people with a learning disability. So it's quite incredible that that there are actions that we can take that can really improve the quality of someone's life and well-being to ensure that they can lead a long and full life. Most highest noted causes of avoidable death are cardiovascular disease and respiratory disease. So really quite common factors indeed. If we can move on, another slide, please. So you might not, judging by the poll that was taken at the beginning, you might not all have had the opportunity to report a death, but and those can be undertaken easily through the Leader website, which I believe the link is also will be put into the chat. It takes 5-10 minutes to complete the reporting, and anyone can do it, and that will go through to your local Leader team, who will then review that process. So if you're not familiar, just click on the link and have a look at the process. But it's definitely not an onerous task, and will greatly benefit the people of the Southwest, but also understand where we are nationally as well. And I think I might have one final slide. Oh no, right. So I'm about to hand over to my esteemed colleague, Dr. Rachel Gaywood. But just before I leave you, I suppose from a regional programme point of view, Leader is core to our delivery and supporting our health inequalities programme. I think what we've got coming up is, and one of my colleagues can talk about that a bit more shortly, is we're going to run a reasonable adjustments event in the Southwest, really looking at how primary care can support reasonable adjustments in practice and improve that attendance for people with a learning disability in surgery. But also our ambition is to develop learning disability champions across primary care, so that actually we have a point of contact to look at innovation and improvement. So with that, I'll just say thank you very much. If you have any questions, my colleague Nikki Powell can answer them. And now I hand over to Dr. Rachel Gaywood. Rachel, over to you.
Thanks, Graham. And we are 5 minutes ahead of time, so this is great news. Because I have been known to go on a little bit. Can we go to the first slide, please? So this is me. I'm Rachel. I'm a GP down in Torbay. I do that 2 days a week, and then the other 2 days a week I spend working for NHS Devon as the clinical lead for learning disability and neurodiversity. We can go to the next slide. I've been given the tasks of doing an overview of annual health checks in 10 minutes. So these are all the things that Alison asked me to talk about. What's an annual health check? Who's eligible? How do we identify people? And a bit about accessible invitations, the process of doing annual health checks, a bit about medication reviews, health action plans, and some resources. So let's go. So what do we know? Obviously, we've heard from Graham about LEADER. We know why it's important that we do annual health checks. The good news is that there is some evidence out there that the health checks do meet these unmet health needs, and they do other things as well. So they also give us an opportunity to make sure that we're doing screening, the appropriate interventions at an early stage. They also give us the opportunity to get to know somebody. And then we can, know what their baseline is, so that when there's a change in between an annual health check, we can pick that up and they feel okay about coming to see us. So they're familiar with the health environment. So it's not just about the once a year, it's about knowing who your doctor is, who your nurse is, where the surgery is, and feeling okay with that whole process. So if we go to the next slide, if that's not incentive enough for us, we'll briefly talk about the other incentives, which are the financial ones. So apologies for anybody who knows all of this already, but I find that often people don't really know about how the annual health check scheme works. So general practice, without getting too political, GPs get paid less than £100 per patient per year to provide all of that person's healthcare. Then there are other things on top. So general practice run by partners who own their own business and who have to, generate income to pay their staff in order to keep going. So there are a number of other things where people can get income. One of those is QOF, which is the contractual chronic disease management type things, and you have to get a certain number of points to reach the targets for those. Then we have things called direct enhanced services, and that's where annual health checks are covered. So a direct enhanced service is not something compulsory, so practices don't have to do the annual health checks. Sorry, I just spotted a typo on that slide. In Devon, all of our practices have signed up, so that's great news. Once practice have signed up, then they get, for every check that they do, they get £140. So target was for the long-term plan, so just finished in March, was to get to 75% nationally, and they've kept that target for the next year as well. So we know we're doing the numbers, and there's lots of work on measuring the numbers. What we don't know about is the quality of those. So there is work going on nationally about a toolkit to kind of come up with some sort of minimum standards, rather than just ticking the box to say we've done it. So we'll talk in a minute about who's eligible, but essentially it's anybody who's on the Learning Disability Register. Good news for us in the learning disability world is that there is added incentives as part of the PCNDES in the Impact and Investment Fund. So you will know that they reduce the number of things, criteria in the Impact and Investment Fund, but learning disability has stayed. So this means that within our PCNs, if we as a PCN do really well in annual health checks, then we get extra points. And points mean prizes. So it's a real incentive to work together across PCNs to make sure that we're getting this right. The PCNDES states that we have to do an annual health check and a health action plan. And we'll talk a bit more about that in a minute. So the next slide. This is similar to what Alison's told us, so we don't need to talk about it too much, but the definition of learning disability. So we know that you need these three things. The good news is, as Alison said, you don't actually need a formal diagnosis. Nowhere in the country has a formal diagnostic pathway that we can refer into. And you could argue, nor should they, because actually all we're trying to do in general practice is get our registers up so that they're heading towards that 2%, because currently nationally we have about 0.5%. So we only have about 1 in 4 of the people who should be on our registers who are out there with a learning disability. We only identify about 1 in 4 of them. If you go to the next slide, please. So what we're trying to do is identify these people. And what I always say to people when I say, if in doubt, put them on the register, is that actually being on the Learning Disability Register doesn't get you anything apart from an annual health check. But that's great in itself. So it's not going to get you benefits, it's not going to get you a bus pass. It will get you an annual health check, and it gets your GP surgery familiar with you, and they know to invite you for an annual health check every year. So that's the bonus of being on the annual health check register. So when I say to my colleagues, they say, well, I don't know if they actually have a learning disability, I say, well, speak to them, speak to their carers, speak to the people around them, use the inclusion tool. And if you all think that an annual health check's a good idea, put them on the register. You don't really lose out from that if you've had that conversation with somebody. So can we go to the next slide? So again, we just need to whip through these because Alison's shown it to us already, but this is the inclusion tool that gets sent to all GPs, made by the team in Leeds, which helps us to have those conversations and identify people. So if we just flick through the next couple of slides, because we've seen them already. Perfect. So this is the factors that might or might not help us decide whether somebody does have a learning disability. And I'd say this is quite subjective, but I think the more you have those conversations, the easier it gets, and the more comfortable we get in having those conversations and adding people on. I've not had anybody tell me that they don't want to be added to the register when I've brought it up with them. If we go to the next slide. So the process of annual health checks. So my first, I changed this slide slightly. The first thing on my the amended slide said find a learning disability champion. So Graham set that up quite nicely for us. What we've done in Devon is when I started this role, we invited all of the practices to nominate a learning disability champion. So it doesn't have to be a GP, it could be a member of admin staff, could be one of the practice nurses. Is the person who is going to champion learning disability in the practice. Now, the benefit of having that is that you have somebody who's that champion and who can rally everybody else to do this work and to keep an eye on things. I find it really invaluable to have a specific admin member of staff who is responsible for the learning disability register and for inviting people in. We don't like having that last minute rush in Q4, which we always have to get these checks done before the end of the year. We try to encourage people to invite them in their birthday month, just like they would with any QOF check, for example. We need to ensure that people have been offered the invitations in an easy read or other accessible format, so that we're asking them what reasonable adjustments they need and whether it would they'd like to have that, for example, an easy read, or do they prefer to be phoned, or would they like us to speak to somebody on their behalf. So just thinking about have we offered that accessible information to them. Some people like to send out a pre-health check questionnaire, which is available on the clinical systems. So we use EMIS, and there is a set of questionnaire on there. Some people say, actually, you're going to ask me all these questions in the check, so I don't really want to do it beforehand. But I think the offer of the pre-health check questionnaire is really useful, because that gives people that extra time in their own time at home to think about the questions and think about the things they want to bring up in the check. So when we book the appointment, we must ask what reasonable adjustments somebody needs. Shaun's going to talk to us a bit more about reasonable adjustments in a minute. It needs to be a minimum of 40 minutes. There's no way you can get it all done in less than that. There is no specific guidance about who should do the check, other than it should be an appropriately qualified person. So some people will have a combination of, they'll see a HCA first, then they'll see a GP. Some people will have the whole checks done by a practice nurse or an advanced nurse practitioner. What we've been trialling in my practice, which has worked really well, is we've had a whole day of learning disability checks where people have been booked in with the nurses, and I've been available as a kind of floating clinician to answer any questions about medication or anything specific that they need from me. We have a pharmacist available as well, and our social prescriber's been there, and that's been really useful, because rather than doing referral forms and having to wait for an appointment with a social prescriber, she's been able to see people on the day, and we found that really valuable. So if you can do a kind of multidisciplinary approach, then I think that works really well. As I say, whether that's a clinic format, or whether that's just knowing who you have in your team and who to ask for things. It's great to see some care coordinators on the call. So within the R's roles in the PCNDES, there is now funding for care coordinators, and lots of people finding it really useful to use those care coordinators to do that coordination of the learning disability register. Yeah, I think it is really positive that we've got some great work going on and some great people out there who are really championing learning disability across the region. Can we go to the next slide, please? So we're not talking particularly clinically stuff today, but just to list the topics that should be covered. So that's why you need plenty of time, because this is quite a lot to get through. It's essentially all the things that people need in a physical health check, and majoring on the things that we know from LEADER that people the inequalities people are facing. So we know that people are not getting screening when they should do, when they're entitled to it. We know that people with learning disabilities die from constipation. I still find that shocking, even though I know that it's true. And all the other topics that you can see listed there, important to cover, particularly in the younger age group, but in all of our learning disability patients, things like sexual health, mental health, the things that we don't don't want to go there and talk about. So specifically, just to mention STOMP, if we go to the next slide, there's some, I've just heard there's some great regional work hopefully going to be going on in STOMP. This is something we've produced in general practice in Devon, just that we're about to send out soon, which is some guidance to support STOMP within the annual health check. So for those of you who don't know what STOMP is, it's the campaign for stopping over-medicating of people with a learning disability, autism or both, with psychotropic medication. So essentially what we've seen in the past is that lots of people without a mental health diagnosis to back this up have been given psychotropic medications essentially to control their behaviour when they've exhibited behaviour that challenges, and we know that that's not okay, and the side effects and long-term consequences of that are damaging for people. So we really need to be, first off, in the annual health check, recognising when people have medications that they, we don't know the indication for and that we need to consider changing, and then making sure that we liaise with GPs, practice pharmacists, and thinking about whether the conditions are right to reduce those medications down. If we can go to the next slide. So this is something we can share that we've just put together to help the annual health check process, and help people to think about that a bit more. Next slide, I think we're nearly there. This is health action plan. So this is the template from EMIS. Other health action plan templates are available. So in contrast to some of like the hospital passports and things, the health action plan is literally 2 or 3 bullet point summary of what you do at the end of the annual health check, what the plans that you've made. So this might be, make sure you see a dentist. It might say blood pressure is high, we need to monitor this at home. It's really just a snapshot of the important points that we've talked about, and it's really important that we do this so that people have some ownership, and then we can reflect back the next year, did we actually follow up on those health action plan targets? So this should be both a physical and an electronic output of the annual health check, and we do have to tick that we've done that to get the impact and investment fund points. So next slide, please. What support is available? So, within your ICBs, there will be somebody leading on this in the commissioning team. So try and make sure you know who they are and how you contact them. As I said, in Devon, we have a champions network. We've got a TeamNet page with all of our webinars that we do every quarter, covering all the important things that we need to cover. So they're all available on our TeamNet page. I'm happy for that to be shared. It's a little bit messy at the moment because my project manager's on maternity leave. We also have a fortnightly meeting where people can come in, just drop in and ask us questions about annual health checks, whatever that might be, whether that's clinical or sort of procedure-based things. And we're always available to answer questions within Devon. So as I say, it's finding your network really and who your champions are and making sure you join up with them. And I think that's me. Thank you. Just to say, sorry, if you want to learn more, if you're a clinician who's really interested in this stuff, there is now a Health Education England funded for 1 more year PG cert in the medical needs of adults with learning disability, which is run by the Royal College of Physicians and Edge Hill University. And for any GPs amongst us, there is a really active Royal College special interest group. So if you'd like to be added to that, let me know and I'll make that happen. So I'm going to hand over to Shaun. It's exactly 1:30, and he's going to talk to us about reasonable adjustments. Thanks very much.
Thank you, Rachel. Thank you. Thank you. So I'm a registered learning disability nurse, clinical project coordinator in the adult learning disability health service in Bristol, North Somerset, South Gloucestershire. Can we have the next slide? Yeah, and so I'm going to touch on reasonable adjustments today. Can we have the next slide, please? I want to look at kind of what they are, what they look like in practice, and consider some methods of how to think about how to implement them as well. So kind of first of all, back a slide please, sorry. What are reasonable adjustments? Can we just, thank you. So they're a legal responsibility for health services under the Equality Act, and as kind of previously covered within the webinar, the learning disability population at greater risk of health inequalities, mistreatment and poor health outcomes, and there's a recognition that not everyone is the same or has the same ability, and that people with learning disabilities are less likely to be able to access healthcare without adaptations. And so we use reasonable adjustments as a way of levelling that playing field for people to access health services. So what do they look like? Well, reasonable adjustments, if you go to the .gov website, you get these large, broad reasonable adjustments like physical adaptations, ramps and rails for access to buildings, or policy and training to help staff support a specific group of patients. But it doesn't have to be big, it doesn't have to be grand, and quite often it comes down to our own individual practice, and we need to consider the individual needs and how we can adapt our day-to-day care to meet the person's needs. And quite often it's those small changes that we repeatedly put in place that can make the biggest differences. So next slide, please. Thank you. So yeah, this is just a plug really for Health Innovation Network video on reasonable adjustments. It's on YouTube. The link's in the slides, and then you can go watch that after this as well to find out some more. Next slide, please. So learning disability services, we're often really good at telling the wider health services to just go and do reasonable adjustments, and we have this expectation that the whole health system is just going to know what they don't know, and you're going to know how to put in reasonable adjustments without guidance. So I want to take you through a bit of a tool, this acronym TEACH, which will help us understand how we can adapt our care and how to implement reasonable adjustments with some quite simple thoughts. So time. This is about time of appointment. So first of all, is the appointment at the appropriate time? Is the person able to make that time of appointment? Should we consider what the person's individual needs are? How do they access appointments? Is it via public transport, and are they able to get to the appointment time? When is there support with them, and is the support able to access them to access the appointment at the appropriate time? So considering that individual need of that person and the appropriateness of the appointment time, but also the length of time during an appointment. Do they need a double appointment slot in order to have that maximum time with a clinician in order to have a proper, robust conversation in a way that they understand, using appropriate tools that they understand? So time. And next one, please, is environment. So if you think of any healthcare setting, and then consider like a list of the worst sensory overloading environments possible, and most healthcare settings cover it. They're noisy, they're bright, they're busy. There's lots of equipment and posters and whatnot everywhere, so that we're starting everybody off on a point of heightened anxiety where they're feeling overwhelmed anyway by the environment. So how can we adjust that environment in order to maximize their ability to access healthcare? So we need to think about the sort of sensory impact of the environment, the noise and the lighting, and how can we reduce that where possible. So when we think about waiting rooms, is there a quieter space for them to wait? If they are finding the lighting overwhelming, can we reduce that lighting somehow? Perhaps find a side room for them to sit in. If they find waiting hard at all, can we get them to wait in their car, or can we have them arrive with an appointment slot ready for them? And that's where a double appointment could be quite helpful for them to arrive at that point in time. But also it could be other things such as how we presenting ourselves as healthcare professionals, and uniforms can be quite challenging as well. So just thinking about how we're presenting ourselves, can we adapt our own personal presentation when we're thinking about environment? Next up, we've got attitude. So this is about our own approach to people with learning disabilities. So firstly, kind of educating ourselves on learning disabilities, and then applying that knowledge to practice. And then it's about confidently asking that person what they need, or their support, what that person needs, in order to identify how best we can adapt our practice to meet their needs. And then it's having a can-do attitude, and just giving it a go, and having that confidence that making small adaptations to our care will make a big difference to that person. Next up, we've got communication. So this is all around how are we supporting that person with understanding everything that we're communicating to them. So from pre-appointment to during appointment to after appointment. And we need to make sure that we're communicating in a way that is accessible for that person. So starting off with like written information, so invite letters, it's already been said, making sure that we've got easy to read invite letters, but also things like ActRx text messaging. Can the person even read those text messages, or are we setting them up for failure, or is a telephone call more appropriate? I had one service user who was never attending their GP practice because they all came through text messages, whereas actually she couldn't read them, and had they come from a telephone call, she would have attended. But also, are we maximising the use of our accurate text messages, and could we embed links in there to send to signpost to easy read documentation which is available? The other thing that could help is think about videos and the use of videos within consultation. If we're trying to reduce anxiety around what we are supporting people with, there's a plethora of YouTube videos out there in supporting people to actually understand that following process that's going to happen. And then lastly, kind of we talk about easy read information, and definitely don't expect everybody to be experts in developing easy read information, but there is loads of materials already available. There's easyhealth.org, and some of the bigger charities like Diabetes UK or Macmillan, they have loads of really great easy to read information that you can access free on their website. So to have a look around and see what's available. And then lastly, on the TEACH acronym, we've got HELP. And this is about involving the person support network in their healthcare, again, before, during, and after, and asking them to help the person to maximise their ability to access healthcare. But we do need to be mindful that we're not overlooking the patient, and that during appointments we are talking to the person, not their support network, and we're involving them in their healthcare. And then it's also a prompt to think about asking for help from the specialist learning disability teams, again, advice and guidance from them. Next slide, please. So now we've just got a couple of resources that we've made locally in the BNSSG area. So this is a reasonable adjustments poster for staff in primary care, and this can sit behind the desk, it can be in your staff room, wherever you feel is appropriate. And these resources are readily available. We can share them out with a pack after today. Obviously, the links on there, they go to the local services. They're free to access. And this is some practical prompts for staff to think about on a day-to-day, before you see a patient, or just throughout your day, thinking about what can I do to adapt my current practice in order to meet that person's needs. And I believe we've covered a lot of that stuff through the TEACH acronym, but it's just another way of visualizing it. Next slide, please. And this resource, again, this is free, and we can share this with the packs. This is a slide deck for TV screens in waiting rooms. This is targeted at people with learning disabilities who would be able to access this level of communication, but also the support staff or someone that might be supporting someone with a learning disability to think, do I or does the person I'm supporting need reasonable adjustments? And I'll go ask a member of the practice staff to help if I do, and we can share that out as well. Next slide, please. So just to finish up, just a plug for the local learning disability teams. And if you are supporting people with learning disabilities and wanting to think about reasonable adjustments, and you're struggling to think about how you can adapt your care, get in contact with your local learning disability teams. In Sirona and BNSSG, we've got an advice and guidance line, which is staffed 7 days a week, that you can just call up and speak about an individual patient or just more generally. And I'm sure that would be something that would be available across the counties, and I would highly recommend getting in contact. So that's me done on reasonable adjustments. I'm going to hand over to Laura now. Thank you very much.
Thank you, Shaun. So my name's Laura Canning. I'm the Health Inequalities Lead for NHS England with the South West Learning Disabilities and Autism programme. But I am a physiotherapist in background and come from a community learning disability team. So I'm here today to talk about how do we work in partnership, bringing the skills and the knowledge from the specialist services and being able to use those in primary care settings. So obviously, thank you, Shaun, for sharing the link for your local team. I understand that the structure, function and referral criteria will vary depending on where you are in the Southwest, and sometimes the names of the teams will vary as well. You might come across intensive assessment and treatment team, primary care liaison teams, community learning disabilities teams, different teams for adults and children, and neurodevelopment teams. So there is sometimes quite a lot of navigation of this. Health and social care teams may vary, but ultimately the teams working in the communities, their role is to provide that specialist health and advice to people with a learning disability, their carers and families, but also that wider health and social care community, to be able to reduce health inequalities and ensure people can access the care that they need at the right time. These are often multidisciplinary teams. They will include nursing, psychology, speech and language therapy, physio, OT, psychiatry, and so on. There are specialist learning disability liaison roles that may sit within or around these specialist teams, and their roles are looking at linking between all care settings. They may sit within the district general hospitals, they may sit within your primary care organisation, and again, it's about supporting people with a learning disability and their support network effectively access healthcare in the right place at the right time. Next slide, please. So I just wanted to take the opportunity just to put a spotlight on the acute liaison learning disabilities nurses. So kind of sitting within the district general hospitals in that acute care setting, and really they're providing their specialist skills and knowledge and providing their expertise on the needs of people with a learning disability. And this may include supporting outpatient appointments, investigations and admission, the discharge process, and they can support with application of the Mental Capacity Act, support with planning of admission and kind of advocating and being proactive around sharing information through the hospital passports. And they, from my experience as a physiotherapist in the community, they are so valuable in facilitating that multidisciplinary communication across inpatient staff, across different disciplines, with social care, with the community health teams, to really take a lead, not necessarily a coordination approach, but really leading those person-centered discussions and making sure that that's coordinated. Next slide, please. So I've just kind of put a few points down to really think about how can we work in partnership between our specialists and primary care services. So as I said, my role as a physiotherapist within the community team, we would definitely provide training with our colleagues in other community rehab teams or primary care to make sure that we were able to design some bespoke and meaningful training that actually represented the population which you serve, because that will vary. Sharing resources, sharing information. So I've got the next slide will just kind of show how sometimes people's needs are so great and the clinicians around that are so varied that it really need to be proactive in sharing coordinating information sharing. As I mentioned, the roles of the liaison nursing roles, providing support for an outpatient appointment which may have come from an appointment within the primary care setting. Kind of working in partnership, how do we implement those reasonable adjustments? As kind of Shaun outlined, sometimes those will be tricky and those will be tricky to manage and may need some recommendations from your learning disability colleagues on what works best. And ultimately kind of bringing that all together, we can look at trying to improve the quality of the assessment and the planning, and looking at how those annual health checks and health action plans are really working for the people that you see. Next slide, please. So I've just shared this slide. This is a slide I've used in lots of different forms to try and communicate lots of different things, but ultimately, if we're looking at the person with really complex needs in the centre and their family around the outside, and some of the challenges that they may face and some of the demands on that person as an individual and that support network, but then around the outside, all of those multiple professionals from different services, from specialist learning disability service, from sat within kind of secondary care specialist consultant services, and just not only thinking about what that person and that family may have to manage on a daily basis, but ultimately thinking that none of these professionals, or no professional that has contact with this person, is on their own. There's lots of opportunities to share information, learn about that person and their support network, and ultimately achieve the best outcomes for that individual. Next slide, please. So as I said, you're not alone. There's often a wide network, the person themselves, their support network, their carers, their family, their advocates, and there may be a cross-organisational, extensive, in some cases, multidisciplinary team involved. And it's all about planning and sharing relevant information. And I think kind of going on what kind of Shaun's discussion about reasonable adjustments, it's also thinking that when we're thinking about enablers to access primary care, these start at the very beginning of a person's journey. So how are we sending appointments? How are these being received? What's that contact like when someone makes a phone call or receives a phone call? And they're not a one-size-fits-all, they're not prescriptive, and they may change over time, and they may be complex. They may change between what's happening with somebody's support network and what's happening at home. So I think there's important things to consider when we're looking at trying to provide successful, reasonable adjustments. Next slide, please. I just wanted to, this is a really kind of brief and basic example. I just wanted to just provide a little bit of an example. So less than a third of eligible women with a learning disability have received a smear test. So this is just thinking about Abby as a 37-year-old living with her mum, never received a smear test, has found some information online, knows it's important, but is very anxious. So how can we work together in partnership to ultimately achieve the best outcomes for her? That might be sharing suitable resources to support her understanding, thinking about those liaison roles and the roles that sit within the specialist learning disabilities team to understand the process, support any desensitization, understand what's going to happen now and next, and thinking about time and planning ahead of the appointment, what appropriate support is needed and what will facilitate a successful outcome. And kind of in an example like this, kind of meeting those needs may achieve a successful smear test for Abby, but in the long run, it may then kind of facilitate repeated screening and engagement with other kind of appointments and screening in the future. Next slide, please. I just wanted to share this. It kind of touches on a lot of what Shaun was already saying, but there's some videos and some paperwork that's been developed by the ACPPLD, which is the special interest group for physiotherapists, about your next patient has a learning disability. It's not limited to physio, but lots of the allied health professional networks have communities of practice and special interest groups for supporting people with learning disabilities, which you can get information from. Next slide, please. And I'll just keep this in, I won't talk about it too much because I know the slide decks will be shared, but we have South West Health and Wellbeing Network, which is kind of almost like a CPD group, mostly professionals working with an interest in learning disabilities that meet and kind of talk about projects and what's going on. So I'll leave that for you to look at in your own time. And I think the next slide is the last slide, which has just got some signposting for you there, and it's not a complete set of signposting, it's just a select few. Thank you very much.
Thanks very much, Laura, and thanks to everybody who's been joining us and putting lots of active questions in the chat. I'm going to very quickly talk about next steps, so if I could have the next slide after that, please. What we're hoping today is giving you a very quick overview of actually the process of and the things that matter if you're looking after somebody with a learning disability. And what we've done is we've developed a very quick checklist that you might find helpful to show evidence of your learning from today. So they're just some simple questions we've put on a Word document. So do you know how to access the Learning Disability Register in your practice? How can you tell if somebody is on the register? How many people are on the register in your practice? Is it 1%? Is it 2%? Do you think you've missed people? Do you know how to add someone to the Learning Disability Register? Next slide, please. And then thinking about annual health checks, just some questions to ask. How many patients on your Learning Disability Register have an annual health check? How are patients invited to an annual health check, and how is the annual health check done? Do you have an appointment with a healthcare assistant or a clinician? Is it done differently? You know, is it, as Rachel says, you might have an annual health check day? And there have been some questions about the length of appointments, and it very much varies according to your practice. But if you know a bit more about how it's done, even if you don't actually deliver the annual health checks, then you can help reassure people what will actually happen on the day. Next slide, please. And then the final set of questions we put in was on reasonable adjustment. So how do you know if somebody needs a reasonable adjustment? Are the pop-ups there? As Nicola and Graham have both said, there are some reasonable adjustments, digital flags are being developed. We're going to have a webinar, a specific learning session on that, which will be learning disabilities and wider. But just for the start, are you flagging if somebody needs longer time or help with communication? What reasonable adjustments are routine in your practice, such as longer appointments? How do people with a learning disability make an appointment? It's challenging enough for all of us, sadly, with the pressures on primary care. But if you've got difficulty speaking, how do you do it? And does your practice have a learning disability champion, a recurrent theme? Next slide, please. So just to flag that today's been very much processes, looking at leader, perhaps, you know, looking at the definitions, reasonable adjustments, the process of delivering an annual health check. And the next webinar we're doing on Monday, the 17th of June, which is when we're looking at clinical considerations. So some of the things that have come up in the chat, like oral health, a very brief mention on assessing mental health capacity, and looking at some of the more common conditions in people with a learning disability, such as epilepsy or respiratory conditions, cancer screening. So it has been a real gallop through, and we do apologise that we haven't had a huge amount of time. But if you've got any questions, I'm looking at Susie. Shall we, you know, if you want to ask a question now, we've got 5 minutes before that. Is that okay, Susie? Shall I hand to you?
Yes, we do have 5 minutes in hand. Thank you so much to all of the very good timekeeping. Just in terms of the document that you just mentioned, Alison, I haven't been able to add it to Teams, but we'll make sure that's included when we send these slides and all the other resources around. So that will be going out to everybody. So
perhaps actually then, if rather than put the questions out generally, if we could pick up one of the questions that came in the chat, and this was for Rachel, because it's a really important one. Rachel, do you have a policy, Rachel Gaywood, do you have a policy of what you do if a young person isn't brought to their annual health checks because of their parents or carers don't bring them? Perhaps we could stop sharing actually now, Teresa, so we can see a few more faces. Oh, I've just seen as well, joining the 17th of June webinar, we'll send the links out for that one.
So yes, in answer to your question, I have in my practice we have a was not brought policy, and there has been there's a toolkit, isn't there, that was sent around from the region a few months ago,
North East
which
England,
is,
you're right.
yes, which was promoting was not brought rather than did not attend. So it's thinking about it very much more in the context of being a vulnerable person, in the way that we do if a child isn't brought to their immunisations, but considering that, you know, our adults with learning disability, whatever age they are, rely on other people some of the time to bring them to appointments. So I wouldn't ever declined an annual health check unless I'd personally spoken to them and assessed that they had capacity and, you know, that they knew why and had reasons for not accepting the annual health check, because I don't think it's okay just to decline people. So I always recommend that, you know, anybody who hasn't been for their annual health check, you look at their notes and you try, you know, attempt to contact them and find out why. And then that picks up, you know, sometimes safeguarding issues, rarely, but yes, absolutely. We know that people with learning disabilities are more vulnerable to, you know, abuse and to need safeguarding. So
thanks very much for that, Rachel. And I've just noticed that somebody's asked about having advocates and people with a lived experience of a learning disability on their patient participation groups. And I wanted to flag earlier, some people may have met him at the beginning, but I wanted to thank Andrew Bright, who's an expert with lived experience for learning disability in Leeds, who's worked with us very closely to help to develop some resources and some videos, which we've got nearly 250,000 views. So thank you, Andrew, for your help on that. And it's something that we usually do at these webinars, but because today's been so quick, rushing through delivering lots of information, we are aware that we haven't had experts with lived experience. So thank you, everybody. I'm going to hand over to Susie to close the webinar, but thank you very much to everybody who's been speaking for the timekeeping and all the work you've done sharing the literature and evidence. I hope people have found it useful. Susie, over to you.
Thanks, Alison. Yeah, nothing more to add really, other than thanks again to all our speakers, and thanks to everybody for being so active in the chat. We hope to see you at our next webinar or future webinars, and I'll put a link in the chat in just a few seconds for to sign up for the June event. And I hope you all have a lovely afternoon.